this to an NCIS toxicity webinar. I think we have a star-studded cast with us tonight. We have Dr. Bonney from Division of HPB Surgery, Dr. Rahul from Interventional Radiology, Jang, we have a up-and-coming respiratory physician, and we have the very senior Dr. Arvind from the Department of Nuclear Medicine. We chose a very interesting case. It's more like a mystery that we have to solve. And I think between the 5 of us, we'll try to solve this mystery of why this patient developed what we think is potentially our first case of radioembolisation pneumonitis. Because I don't manage HCC, I've asked Dr. Glenn to specifically stop me if I say anything out of order. Okay, I'll present the case quickly. You can see my first slide. This was a 77-year-old Malay man with some usual cardiovascular risk factors. He was diagnosed with a right lobe hepatocellular carcinoma. You can see there quite a large mass, and it was probably deemed unresectable at the start. So he had an IR angioembolization of the hepatic artery in May of last year. I put there the description, a summary of the procedure. About 60% of the territory was embolized and stopped at that point to limit complications of post-embolization syndrome and liver dysfunction and so on. 2 months later, he had another assessment scan which showed shrinkage of the tumor. And so it was contemplated for either Y90, yttrium-90 therapy, or surgical resection. So because of some abnormalities on the cardiac scan, they opted to go for Y90 workup and treatment. So he had Y90 treatment in September of last year, and 3 months later, it again showed a good result. There was reduction in the hepatic mass, and because the cardiac risk was deemed acceptable, the ICG was adequate for surgical resection. So it was planned for a right hepatectomy. However, the operation was cancelled due to what was deemed to be a community-acquired pneumonia at that time. Actually, the patient had been breathless for a few months, right? And despite treatment with antibiotics, several courses, RCCM was called into the picture. Bronchoscopy, DAL was done. The patient was started on steroid treatment. That's his HRCT thorax in January, which showed widespread consolidative changes, ground glass opacities, early fibrotic changes. The considerations were that of atypical infection and post radioembolization pneumonitis. The patient did not respond, and he had progressive shortness of breath, and he passed on in March of this year. Next slide. Put together the various nuclear procedures. So if you go to the pre-Y90 lung shunting scan, if I'm not wrong, they do this to see whether there would be significant shunting of the radioisotope to the lungs. In this case, there was acceptable liver to lung shunting. Right? The figure quoted here was 6.1%. This was deemed to be not significant. And more than that, they did another scan post-treatment. So we see here in yellow, there was good localization of the radioisotope to the tumor in the right hepatic lobe, but no significant activity elsewhere, right? However, the patient developed what we thought to be similar to reports in the literature. I won't go into the details because that would steal the thunder from my fellow speakers later. But just take a snapshot of this CT scan. Um, and we'll see what the others also have to say. Okay, so we'll move on to our second presenter because I don't know much about liver cancer and when and why we should use Y90. So I've asked Bonney to give us a rundown of this.
Thanks, Alvin. I'm not going to go into too much detail and bore everybody. So just a sort of 5 slides to briefly describe Y90, its uses and indications to date. Um, Right, so it's clinical application. So it's otherwise called CERT, as we know, or radioembolization, as Rahul's going to talk about. More recently, we started to segmental radioembolization, and I won't go into the technical descriptions of that. Essentially, it's an intra-arterial delivery of Y90 with microspheres into classically hepatic tumors, but increasingly there's more and more indications that we can talk about. In terms of regulatory approvals, it's been going for nearly a quarter of a century. FDA approved TheraSpheres first for unresectable HCCs, and then shortly afterwards it was approved for metastatic colorectal cancer. And then Europe started to include neuroendocrine tumors and actually finds its way in the ESMO and CIRS guidelines as well. Some off-label investigational uses, but currently increasingly used. We've done this with us with in our center as well, is for cholangiocarcinoma. And being a transplant center, quite a lot of our patients are often bridged and downstaged for their HCCs into criteria for transplantation. And we'll talk briefly about this shortly. So the benefits to our team of liver surgeons, firstly, is about downstaging a tumor into resection, as we've just heard a little bit from that presentation. So Y90, as we all know, can actually shrink a tumor that was initially considered unresectable. But there's two things, caveats, that is interesting to learn about that. One is that not only does it shrink the tumor, the liver then starts to grow the remnant liver. So if you were to treat the right lobe, the left lobe starts to hypertrophy. So essentially, if you're downstaging a patient into a resection, you're now leaving behind more liver. The second part about it is that growth rate is actually something that happens over 3 to 6 months. So just because a patient hasn't grown enough liver in the first month to 3 months, don't give up, because often that can happen 6 to 9 months later. And DDI and myself have got some patients that we've done this, where we've done Y90 thinking it's unresectable, and then 6, 9 months later, have gone in and resected these patients. So it allows for conversion to surgical candidates. Bridging to transplantation is the other important thing. So we know that there's criteria for liver transplantation called Milan and UCSF. A lot of these patients present late, so these tumors are outside of that criteria. Nationally, we have now in the last 2 years accepted that if you can then bridge these patients who are once outside of criteria into criteria, we can transplant them, and we've done a fair few of those. You're allowed with Y90, unlike radiofrequency ablation and a little bit of TACE, you can do this multifocally in bilobar disease. It spares liver function, and that's because it selectively targets tumor vessels and preserves the surrounding parenchyma. And very cautiously, we've adopted doing so in portal vein thrombosis as well. So patients who have liver failure, often their portal vein is thrombosed. And initially, in the experience of Y90, there have been some concerns that if you have that portal vein thrombosis, it wouldn't be a good idea to then go on and do Y90 through the artery. But actually, even in our series, we've started to do this and actually done so safely. Just a little bit of data. This is probably the most recent one, very large series, but I mean, as oncologists go, you look at these numbers and say, what large series? This is tiny. But as a surgical series, this is probably the largest in the world from Spain. And they're just looking prospectively at their patients treated with Y90 for what was initially unresectable because of their functional liver remnant. So wasn't enough liver remnant, or initially out of criteria for transplantation. So if you look at the top of this chart, you can see the survival outcomes with months over the bottom. And so if you take a 5-year cutoff, with red being the intrahepatic cholangiomas and blue being the HCCs, you can see that actually majority of these patients are surviving well over more than 50% of these patients are surviving beyond 5 years. And then for liver transplantation is pretty much the same. This is the 5 year cutoff. It's above 50% and continues to be fairly preserved. If you look at outcomes, I just briefly put this table in, not much time to discuss it, but essentially there's very little morbidity and mortality, so it doesn't change the immediate perioperative outcome of the surgery. But perhaps the thing that's the most exciting part in the last 2 years, this has excited yourselves as oncologists as well as ourselves as surgeons and the DDI people, is this is a paper we published 7 years ago in hepatology, and this was looking at 41 patients that were treated or not treated with Y90 and then went on to resection. So this is the Y90 group and this is the control group. And when you go on to do next generation sequencing and site-off analysis from the reactome, you essentially see all these pathways of immune regulation being upregulated. So it appears that that Y90 starts to basically cause a huge uptitration of immune cells. And there's increasing data to show that actually, if you then bridge into immunotherapy, there is quite a significant effect on improvements in survival. So I think I just wanted to stop there to just sort of give you a whistle-stop tour of what Y90 is like to date.
Very nice, Glenn. I think now I know a little bit of the why we use the Y90. Okay, but more action now. I think is Rahul here with us?
Yeah, hi.
Hi, Rahul.
I am
Great.
trying
So,
to log in using a desktop, hospital
okay.
desktop, which is not allowing me. So I'm only holding on to my handphone.
Yeah,
I'm
same here.
still in hospital, thanks to Glenn. And so, yeah,
And
so if
slides loaded
somebody
up.
can share the slides and start,
Okay.
then yeah.
Anyway, Rahul,
So,
thanks for always looking at scans for us to see whether you can intervene.
yeah. So if Cheryl may share the slide, I can just talk through those.
Yeah. Okay, there's a suggestion that we get the next speaker to go first. Is that okay? While they sort out the slides.
Right.
Okay, we'll move to Dr. Justin Jang. So Justin and team were called in to assess the patient when he developed symptoms and lung changes. So Justin, you want to tell us what happened and
Yeah,
work?
so maybe you can pull up my slides. But yeah, essentially I was called as I reviewed the patient as part of a blue letter in the ward before he eventually dropped down to ICU. So just a brief summary of the case vignette. Essentially, he's a 77-year-old Malay male. I mean, background, he has HCC, for which he underwent radiation yttrium therapy. And subsequently, he actually first presented in January with very infective-like sounding symptoms and was treated for community-acquired pneumonia with augmentin and azithromycin, and subsequently was discharged and eventually represented in February, so shortly after, with persistent shortness of breath on exertion and persistent cough that was not getting better. And antibiotic was escalated all the way to IV meropenem. And eventually, when I was reviewed the patient, he was already on day 6 of meropenem. And despite that, his hypoxemia was getting worse. He was developing severe type 1 respiratory failure. So maybe at this point, I'll just share a bit more about radiation pneumonitis briefly, and eventually what are some of the differentials that were considered and how did we arrive at why we think radiation pneumonitis as a result of Y90 could have been a differential. Next slide. Yeah. Yeah, so some definitions. So radiation-induced lung injury encompasses both radiation pneumonitis and radiation fibrosis. And the duration that we're looking at is 6 months. So anything more than 6 months, radiation fibrosis, that's something that's persistent, as opposed to radiation pneumonitis. Next slide. So some risk factors in terms of development of radiation pneumonitis actually can be split into treatment-related, patient-related, or tumor-related factors. And treatment-related factors actually depends on the radiation therapy, the field, the dose in itself, the fractionation, and whether or not there's concomitant chemotherapy and immunotherapy that's being used. And like what Dr. Glenn mentioned earlier, specifically to Y90, it also depends on the microsphere, the type. I think there is both resin as well as glass microsphere, which I'll let the subsequent speakers expound a bit more about later on. Next slide. Next slide, please. Yeah, so with regards to tumor-related factors and patient-related factors, so patients who are elderly, as well as if they have comorbidities, for example, ILD, or depending on the tumor load that they have, these are also risk factors in terms of development of radiation pneumonitis. So with regards to clinical features of radiation pneumonitis, unfortunately, it can be quite a sinister presentation and can be rather non-specific. And the symptoms that usually patients present with include that of a non-productive cough, dyspnea, which is what you would see actually in infection, or given that they may be immunocompromised, depending on the type of treatment that they are getting or any other comorbidities. They are actually prone to getting opportunistic infections, and there are other considerations, like for example whether this could be drug-induced pneumonitis. So there are a lot of mimickers, and the symptoms can be pretty vague, as you can see. So in the acute phase, cough, dyspnea, non-specific chest discomfort, low-grade fever, things that are pretty common in terms of symptoms. And eventually, even if they were to develop radiation fibrosis, the symptoms are still pretty non-specific. Next slide. So some differentials that we would consider when, especially in the patients with risk factors and the relevant hosts, like such as in our patients with cancer. So some relevant differentials would definitely be that of infection. And of course, for infection, it would also depend on the type of infection, and we have to entertain things like virus or even atypical infections or even fungal in the right context. So other differentials to entertain will include things like organizing pneumonia, which could which could happen in patients with underlying malignancy, and of course drug-induced pneumonitis, especially if they have concomitant chemotherapy or even immune checkpoint inhibitors. And other so other differentials we will also consider would also definitely include that of progression of cancer, especially if there is lymphadengic spread. Next slide. So the next slide is just a brief slide on the classification of the severity of radiation pneumonitis. There are actually a few classification tables out there, but generally it is by whether or not the patient is symptomatic or asymptomatic, and subsequently the degree of symptoms and degree of lung involvement, and eventually whether or not the patient needs oxygen, and eventually the endpoint of death. Next slide. So with regards to imaging, specifically for radiation pneumonitis, it can be pretty non-specific, but some of the signs that would clue us in or suggest that it could be radiation-induced is based on lid review, is that the two most common findings are actually ground glass opacity and air-space consolidation. So the rest of the signs, like for example, halo sign, which we would see in fungal infection, or reverse halo, tree in bud, which are all pretty non-specific radiological signs, which you would see more in the setting of infection. They are not as specific, but the more common findings is actually that of ground glass and airspace consolidation, which you would expect to see in infection as well, or even in organizing pneumonia. So in CT scan, classically, or even chest X-ray, there can be this straight edge sign with regards to the pattern of consolidation or ground glass, which is what the radiation therapy, the field of radiation would actually encompass in the lung field, which would give this straight edge sign, which would clue you in that this could suggest that this is radiation pneumonitis. Next slide. Yeah, so if there's a straight edge sign where it's conforming to the radiation field and progressively becoming like reticular or linear in progression, so that could actually clue you in that this could be radiation pneumonitis. But otherwise, the findings can be also pretty non-specific. So in summary, I would say that to diagnose radiation pneumonitis, it would be taking everything into consideration, including the clinical profile of the patient, excluding the relevant differentials in the patient, and eventually considering his blood tests, his imaging, and as well as the patient as a whole before coming to this to the consensus. So for our patient, like what Dr. Alvin mentioned earlier, when he was eventually treated in his second admission, where antibiotics was escalated to meropenem, by the time I saw him, he was already on 6 days of IV meropenem, which would pretty much cover most bacterial. And despite that, he was still desaturating. And eventually, when he went to ICU, he was I think he was on venti mask and eventually placed on high flow nasal cannula. And we arranged a urgent bronchoalveolar lavage to actually screen for rarer infections, including atypicals, fungal infection, and including PCP as well. So the PCP, the Gram smear, so very quickly, because we had a suspicion of radiation pneumonitis, given the temporal sequence of progression, very quickly when the initial Gram smear eventually resulted negative, including the fungal smear, the TB star, the AFB smear, TB PCR, when all these returned negative, decision was made to initiate the patient on steroids. And he actually managed to turn around following the initiation of steroids with improvement in his oxygenation. And we could actually wind down his oxygen from high flow nasal cannula to eventually 2 to 3 liters of nasal prong, for which he eventually made it to the general ward to continue rehab. But unfortunately, he eventually in the gen ward, he developed a MI. He had a cardiac arrest. He developed an MI, went for emergency corals, and subsequently the trajectory from there became a bit more dicey. So in the next few slides, I'll just share some of the imaging that you would see in radiation pneumonitis, just some of the images. So as you can see, maybe we can just play the CT. So on the left, you can actually see some fibrotic changes and opacities suggestive of radiation pneumonitis. And on the right, you can actually try to see the straight lateral edge sign that I was talking to you about in post radiation pneumonitis. You can actually see a very nice straight edge kind of appearance on the CT. Next slide. Yeah, so these are just a few more CTs of patients with radiation pneumonitis. Yeah, so this is in the setting of radiation fibrosis, whereby there is fibrosis, architectural distortion, and with ground glass. Yeah, in view of time constraint, maybe we'll just move on to the next slide. Yeah, so this is just some still images of what we have discussed earlier. And I think this is where I want to talk a bit more about our patient and some of the papers that are out there. So this is just a case series that I found in 1994, which I think Dr. Alvin briefly mentioned as well at the start of his introduction. So it is actually on Y90 radiation pneumonitis, and these were just some of the CT, the X-rays as well as CTs that were actually published. And it appears that in Y90 radiation pneumonitis, there appears to be a preferential posterior distribution of consolidation with less perihilar involvement, and there's actually a sharp lateral border sparing the pleural surface that has been described. And because it is hypothesized that Y90 microspheres, they actually are pretty small and they are lodged in the small pulmonary arterioles. This is why it results in this radiological pattern. So I'll just juxtapose these images with our patient in the next slide. So as you can see with the 3 X-rays at the top, this is actually the X-ray images of our patient. On the left is actually his initial chest X-ray before he received his Y90 injection. In the middle is his January admissions chest X-ray. And on the right is actually his X-ray in his second admission, where despite being treated for presumptive community-acquired pneumonia, his symptoms remain persistent. And there appears to be, a sense of familiarity. I mean, if you compare it with the case reports, it looks pretty similar, right? I mean, there is this perihilar distribution, consolidation. And if you look at the CT in the next slide, you can actually see this described preferential posterior distribution of consolidation and sparing the pleural surface. Yeah, so with that, by excluding the various differentials and looking at the CT images and taking a clinical history from the patient and also covering the patient for infection, we arrived at the diagnosis of radiation pneumonitis in his initial part of stay where he was treated with steroids before his eventual deterioration with MI and his subsequent progress. So just my last slide, I'll just touch a brief on about the treatment of radiation pneumonitis. So largely it still involves the use of predominantly steroids, and it depends on the severity of the patient's radiation pneumonitis. So if the patient is symptomatic, you can initiate the patient on steroid, and the classical description is actually at 1 milligram per kg per day orally. And if the patient remains symptomatic or continues to deteriorate, whereby hypoxemia is, the patient has worsening hypoxemia, requires intubation, you can actually consider pulsing the patient with methylprednisolone. And subsequently, following the initiation of steroids, you can consider tapering them off across the next 2 to 3 months. Yeah. So, I've come to the end of my part. So I'll hand over the time to Dr. Rahul. Yeah.
Thanks, Justin. Now we got Dr. Rahul's slides up.
Yes.
Okay, all yours. Tell us what happened at the procedure.
Hi, hello. I think my slides are generally on what is the thought process behind different types of Y90 radioembolization strategies we use in different kind of patients. Not so much in particular to these patients, which we actually can talk about later during our discussion. Yeah. So as we know, there are 3 types of radiations which are primarily used for therapeutics: alpha, beta, and gamma, and based on and they are different in their mass, charge, speed, and ionizing effects. So beta radiation. So Y90. Next slide, please. So Y90 is essentially a pure beta emitter, and it causes ionization radiation-induced cell death by various mechanisms similar to other radiation that we are more familiar with, the external beam radiation therapy. The fundamental mechanism behind using Y90 or an intra-arterial administration of a radioisotope is to increase the radiation dose to a specific area, thereby preventing collateral damage to the rest of the organs. And thereby you can also achieve in high levels of radiation or the dose that is essentially required. Essentially, I mean, everything can be killed with radiation. It's just that how much can we deliver in without killing the liver or with killing the patient. So essentially, it's a microscopic brachytherapy where the particles are lodged in the parenchymal bed. They stay within it. Next slide, please. And the maximum penetration is about 11 millimeters. So where we inject it, the beta radiations don't travel too far. They are within 1 centimeter. So the radiation damage is restricted to that. But besides that, there are several other factors which can sometimes result in inadvertent mobilization of particles to the areas where we don't require them. Radioembolization, compared to the more commonly formed TACE, has very minimal hypoxic or ischemic result because there is always a sustained forward flow after the end of the treatment. And the particle size is set such that it travels very distally. Talking about indications, as Glenn was mentioning about it, 2-3 years back, these were the 4 special situations where we used to advocate use of radioembolization or Y90 over TACE in setting of portal vein invasion, single lesion which is less than 8 centimeter, downstaging or bridging for liver transplant, or the lesions which are not responding to TACE. But nowadays, with the advances in dosimetry and how we plan the procedures, radioembolization has role in almost any stage of local to locally advanced HCC. It is just titrating the dose and targeting the liver. As long as there is like a sizable greater than 30% of the liver which is not involved by the tumor, we can treat and all stages of HCC, and as long as there is enough liver reserve. Yeah. Next slide, please. So talking of the Y90 particles, there are two types, glass and resin. We commonly use resin microspheres, which are lighter and their specific activity is less. That means the activity associated with one particle is almost 50 times less than that of the glass, which means that we have to inject a lot of resin particles compared to glass particles. Both these agents have some pros and cons. Next slide. Generally, for small masses where we are aiming for radiation segmentectomy, we prefer TheraSpheres or the glass-based microspheres. And for larger tumors, next slide, the agent that is often used is SERT spheres or SERT spheres. These are manufactured locally in Singapore itself. In fact, the facility is very close to NUH. Next one. If you see the address, it is in Science Park, just next door only. Next one. So one strategy that is commonly employed for treating small tumors with an intent of curative ablation is radiation segmentectomy. It is similar to surgeons resecting involved segment of the liver. So very high doses of Y90 are delivered to the segment which contains the tumor. So the idea is not to just kill the tumor cells, but to get good enough margin and ablate the entire segment, usually reserved for less than 2 segments. So this is one case which we did last year, as almost 4 centimeter fat containing HCC, and we planned a radiation segmentectomy of segments 4 and 4B. And after 1.5 years, next slide, please. So there is no, there was good localization on post-treatment scan, and after 1 year and 4 months, there is no viable disease. Next slide. Another strategy employed is radiation lobectomy, which appeals to the surgeons. Glenn was mentioning about it. The goal of treatment here is to potentially cure the patient and also to induce contralateral hypertrophy in the future liver remnant. And also it serves as a test of time to test the disease biology, whether the disease is fast progressing or it is something which is, it keeps the tumor progression in the check and also benefits in the form of contralateral hypertrophy for further surgical planning. For all these various treatment strategies, there are recommended dose levels to the involved segments or the part of the liver which is not containing the tumor. And generally for tumor, we aim to achieve a dose of more than 200 grays for glass and more than 250 grays for the resin microspheres. Next slide. So this is one of the case from a year and a half back, large HCC occupying almost all of the right lobe of the liver. And the lesion is touching the portal vein bifurcation, very difficult to resect. Plus, there is doubtful future liver remnant, whether it is enough for the patient or not. So patient had radiation lobectomy. Next slide. Around close to 4 grays of radiation dose was administered to the entire lobe. Patient want to have after 6 months, there was good tumor shrinkage. The tumor biology was not very aggressive, and there was a positive increase in future liver remnant, and patient went on to have a resection, and now there is no viable disease on the follow-up MR. Next slide. So besides these curative intent treatment, Y90 can be used as a palliative procedure to control the disease in setting of a multifocal disease, such as whether that is restricted to one lobe. Next slide. Or it has spread to both lobes of the liver. Next slide. or in the setting of whether the tumor has gone on to involve the portal vein branches. So all this is that it involves a bit of planning, and with the treatment intent and liver function in mind, various approaches can be used to get the desirable outcome from Y90 treatment. Yeah. Next slide. So advantages in early stages when we are comparing with, say, for example, thermal ablation. Yes, this procedure doesn't require any GA. It's a safe procedure. There are no like direct injury to the liver and all. Other than it's being very expensive, I think it's probably one of the safest approach for very small tumors. For intermediate stage HCCs, it has radioembolization is slightly less embolic compared to TACE, and especially useful in cases of portal vein invasion. There was one comparison in 2022 between DAPTACE, which is the uh, chemoembolization using drug-eluting beads, versus the Y90, and it showed some benefit in terms of stable disease, almost like an additional 1 year of tumor stability was observed. Next slide. And as Glenn was mentioning about the effect of Y90 on the tumor microenvironment and the immunogenicity, which is basically leading to this growing interest in combination therapies. And at every stage, again, uh, there is some benefit that can be achieved with combination strategies, be it in early, intermediate, or advanced stages with the immune checkpoint inhibitors and molecular targeting agents. And the advantages in early stage can be selection of less malignant colon under unaddressed microscopic disease. And in the later stages, it can result in immune modulation, increase overall survival, and in cases which are still potentially resectable, hypertrophy of future liver remnant, as we shown in the one of the cases just now. So this is something which is coming up now with lots of trials undergoing in our setting as well as in the Western world as well. Next slide. So coming back to the risk involved, which is probably the topic of discussion today. So the risks are basically because of unintended transgression of particles to the organs or the areas where we don't want to them to travel. It can cause various forms of radiation-induced injuries. The most common syndrome by far is post-radioembolization syndrome, which is a self-limiting illness with features, complaints of nausea, vomiting, abdominal pain, likely because of triggering of the inflammatory cascade. Symptomatic treatment is good enough for most of the cases. Next slide. The serious ones would be radiation-induced liver disease. It's a clinical syndrome predominantly characterized by jaundice, ascites, and hyperbilirubinemia. And underlying mechanism proposed is radiation-induced endothelial cell damage to the sinusoids, which initiates inflammatory cascades. In predicting these, probably LB score is a better prognostic tool over a child's puke score. Those thresholds, which we just mentioned, which I briefly touched in the previous slides, if we stick to them, and if there is greater than 30% of functional liver volume, the chances of radiation-induced liver damage are very less. And again, we have to be careful in patients with hyperbilirubinemia or ascites, wherever there is like signs of synthetic liver dysfunction. There is some role of prophylactic ursodeoxycholic acid or a tapered methylprednisolone dose in high-risk patients. Next slide. Similar to radiation-induced liver damage, another damage that can happen is radiation-induced lung injury. In acute phase, it can result in radiation pneumonitis, and in chronic phase, it results in radiation pulmonary fibrosis characterized by dyspnea and restrictive ventilatory dysfunction. Underlying proposed mechanism is the hepatopulmonary shunting, whereby the ectopic, which can result in ectopic microsphere migration through the arteriovenous shunts into the lungs. And as Justin was mentioning about their size and typical CT appearances, they get lodged into the almost like the mid part of the pulmonary arterial vasculature and cause radiation-induced damage to the pulmonary parenchyma. No statistically significant correlation has been found between lung shunt function magnitude and the type of microsphere. Diffusing capacity of lung is probably one of a good prognostic marker in early identification of significant radiation-induced injury. In fact, there is some protocols which advocate a serial assessment with DLCO after every 3 months of this radioembolization treatment. Initial management, as was discussed, consists of high flow oxygen and symptomatic relief with the timely initiation of corticosteroids. And there are some case reports where antifibrotic therapies have also been tried in 1 or 2 cases of radiation-induced damage from Y90 treatment. Next slide. Similar to lung, liver and lung, there can be damage to the gallbladder, which is most often not so serious and almost very seldom leads to like a surgical cholecystectomy. Next slide. The radiation-induced gastrointestinal injury is more common than all these serious injuries that we were talking about. In acute phase, it results in nausea, vomiting, abdominal cramping, diarrhea in certain cases. In chronic cases, it can result in malabsorption syndrome, weight loss, and other manifestations. And again, in the acute phases, the treatment often, the symptoms can be controlled with symptomatic treatment. These radiation-induced gastrointestinal injuries is more because of is more common in treatment of left-sided tumors, wherein some of the particles can travel into the gastric arteries and reach the stomach. Or in certain cases, they can reflux into the gastroduodenal branches, causing damage to the duodenal mucosa. But with the selective cannulation and careful planning, it is actually not very serious, and most of these cases are often self-limiting. Next one. So in conclusion, nowadays, I think Y90 has a role in almost all stages of hepatocellular carcinoma and also in some liver-limited metastatic disease. And definitely the role of combination treatment therapies is on the rise and complications. I think the serious ones are the liver and lung injuries, and with careful patient selection and dosimetry are perhaps the things which are required in reducing these complications. Yeah. Thanks.
Thank you, Rahul. Very quickly, we will move on to the last speaker,
Please.
Arvind.
Okay.
Can you tell us the role of nuclear medicine in all of this, and perhaps give us some clues as to why this patient still developed?
So can you see my slide here?
Yes.
Can you see my slide?
Yes.
Okay. So I think most of the things about radiation, Rahul already talked about this one. So let us start. It will be very short and sweet one. So I want to let you know the first brief introduction about the radioisotope used for therapeutic purpose in our hospital at any age. And these are the radioisotope used in our hospital. The first most commonly used iodine-131, mainly for the thyroid cancer and thyroid disorder. It has both component, radiation component, beta and gamma. Beta is used mainly for therapeutic purpose because it travels very short distance, and energy is very high to damage the DNA helical to dysfunction the cells. Gamma imaging, generally the gamma radiation mainly used for the imaging purpose. And second is lutetium, is we use for the prostate cancer, PSMA, lutetium-177. Third one is coming radium alpha emitter is Jofigo. We use for the bone palliation in our hospital from the prostate cancer. The beauty of the alpha emission is travel only 0.1 millimeter in the tissue. So it damaging around the 8 cell size is travel the radiation around the 8 cell size. Next radioisotope, we use rhenium, and we use for the radiosynavectomy for the rheumatoid arthritis, hemoarthrosis, or any type of degenerative changes, we can use rhenium. And last but not least is Y90. And I will let you know that the Y90 also used for the radiosynovectomy for the bigger joint like a knee joint or hip joint. So let us talk about the what is the physiology of this Y90. It is a pure beta emitter. Energy is a zero point 0.9 million electron volt. Average and max is go about 2.2. It deliver about 94% of radiation in 11 days. Half-life is around 2.5 days. So every 2.5 days, the radiation burden decreased by half. And it travel only 2.5 millimeter in diameter. So it travel damaging around 200 to 250 cell size. Once he is stuck in the any end arteriole, so it damages around 200 to 250 cell size. It come into form. Already Rahul tell you about the Y90 resin microsphere and Y90 glass microsphere. So next one, the side effect. This is the very common side effect. You will get about 10 to 20% get this side effect: nausea, vomiting, loss of appetite, belly pain, low grade fever, infection. Belly pain generally happen because if the stomach and duodenum very close to the site of radioisotope, means overlapping the liver area, then it gets some radiation and the patient gets some stomach pain. We can give the symptomatic treatment with the proton pump inhibitor or the S2 blocker like omeprazole and cimetidine. So these are the very common side effect, but the serious side effect is coming from these are the serious side effect, and sometimes very difficult to tackle this one. These are the first started with the radiation pneumonitis. We are talking about this one, pancreatitis, gastritis, and cholecystitis. And last but not least is Y-induced, yttrium-induced liver disease. Yttrium-induced liver disease is also rare condition because most of the normal liver parenchyma receive their blood from portal vein, and the tumor HCC or is a cholangiocarcinoma. Most of the blood supply coming from the hepatic artery, like a arterial supply, and we treat this group of the tumor placing the catheter in the artery. So the chances of backflow to the portal area or portal vein is very low. So, and if the patients has a normal liver function parameter before the treatment, chances of Y90 induced liver disease is very low. So rest of the other one, lung, pancreas, stomach, gallbladder, extrahepatic organ, it generally happen due to the vascular malformation or aberrant arterial communication with the hepatic artery. So here is some sketch diagram of the Y90 shunting, which caused the radiation-induced injury to the organ. So first on the left side, you can see there's a red line. The red tubular structure is the abdominal aorta, and the black one, you can see the catheter going inside the common hepatic artery, and tumor sitting on the left hepatic lobe. So you can see the left hepatic artery supplying the feeding artery for the tumor, but there is a aberrant artery sitting over here before the tumor, communicating with the stomach. And when you inject the radioisotope, some of the radioisotope diverted to the stomach and it causing problem to the gastric mucosa, sloughing of the gastric mucosa. If we dose diverted to this area, the stomach or duodenum, it's called sloughing and may get patient perforation of that area if depend on the density of the radioisotope. So, and the second one regarding the cholecystitis, you can see the gallbladder also getting the additional aberrant arterial supply to the gallbladder, and it will be, if you inject the radioisotope, it will go in the gallbladder wall and cause the cholecystitis, subhepatic pain. This both situation can be tackled with the radio, like a coil embolization. So Rahul generally do angiography, pre-treatment angiography evaluation of liver vasculature, and if you see this type of communication, then it can be embolized with the coil and minimize the side effect of the radioisotope to this extrahepatic organ. Regarding the lung shunting is a different ball game. It cannot be minimized with the coil embolization because in the tumor, what happened, there is a vascular malformation develop during neovascularization of the tumor. So there is a communication with the arterioportal communication or arteriovenous communication inside the tumor. So when we inject the radioisotope inside, inject the Y90 in the hepatic artery, it will go to the tumor, but from the tumor, due to the communication, it go in the systemic circulation and reach to the lung, both sides of the lung. So you will get some radiation pneumonitis. So to prevent this radiation pneumonitis, we do a Y90 distribution stimulation study with the albumin. The albumin is a particle which is more or less a similar size to the Y90, and we attach this albumin with the technetium-99. Is a very benign type of radioisotope widely used in every nuclear medicine department for the bone scan, other type of scan, general scan. The radiation burden is very low, 140 keV, electron volt. So we do a simulation study with the albumin 2 to 3 days prior to the Y90 treatment, and radiologist put the catheter at the same place where they're planning to put the catheter for the Y90. And after the injection, we bring the patient to our nuclear medicine department and take the image of the chest, abdomen, and pelvis and see how much the activity is seen the extrahepatic area. So this is the one case we did long ago, and you can see there is a intense activity of radioisotope in the liver area, the black one, and in the both lung, both anterior and posterior, there's a mild grade diffuse pattern of activity seen, and the lung shunting was 24%. There is another patient we did in the same simulation study with the MAA, and he got the lung shunting is about more than 20%. So to minimize this, if the patient has lung shunting, then we have to balance the yttrium dose. So we have a guideline for the yttrium dose, how much dose we have to give. If the lung shunting is less than 10%, then we can give the full calculated dose with the partition model. If the shunting is 10 to 15%, then the dose is reduced by 20%, calculated dose. If the lung shunting is about 15 to 20%, the dose is reduced by 40%. And if the more than 20, so then we are not advising to treat with the Y90. So this group of the patient above 20%, we are not treating the patient with the Y90. Regarding the patient we are talking today, this is the lung shunting study done for this particular patient, what we are talking, died with some radiation pneumonitis we are talking. And if you look this lung shunting, this is the TCA-MA study on the left side. You can see the intense albumin activity in the right side of the hepatic lobe. There is a photopenic area, the necrotic tissue, and the surrounding area, some active tumor. And you look at the lung. Lung has a very minimal activity, and it is the lung shunting is coming about 6.1% only. We did a post Y90 scan, and the lung radiation coming about around the 9%. So the question here is, the patient really got the Y90 radiation induced pneumonitis or something else? I have seen the literature I got from Alvin, and the case reported in the Korea, they are saying the lung shunting was 11 point something, above 10, and then they got the pneumonitis. This patient has only 6.1% lung shunting, and the radiation burden only 9.29 gray only. If the radiation to the lung is less than 20, is safe. 10 is really very safe, 10 to 15. You can think about the lung parenchymal disease and the patient has a previous problem, COPD, any scar tissue or some problem, then we can think. But if lung is okay and lung shunting is 6.1%, chances of post-radiation pneumonitis is very low. Whatever literature I have seen, they are talking about around the 10%, 11, 12% like that. And this is the CT scan of this patient. Same patient, you can see the opacity, and we diagnose is radiation pneumonitis. I'm not very sure about this one. Is a radiation-induced pneumonitis or PCP or some organism is growing in this area? But it's still because s- image scan saying there is no activity, significant activity in the lung, which caused the lung parenchymal disease or fibrosis or scar tissue. So this is all from my side. Any question, concern, can you ask at the moment?
Yeah, thanks, Arvind. Well, I'll open the floor to all the panelists to give any insights. Why did this patient develop Y90 pneumonitis? I think the radiology is quite classic. We did a bronchoscopy BAL with
I think
RCC.
There is no histology done on the because I have seen some paper from Europe and they did some histological analysis
Yeah,
and they got the particle there. And so on this ground, the one minus point is the lung shunting percentage and total radiation burden to the lung
yeah,
is one of the factor.
yeah.
So,
I'm not sure in one of the papers they had a similar case.
but what about the lung shunting? Is
They gave
it
some
6% or 10%? About 10%.
they gave some reason why, even with a negative scan, the patient may still develop. Any insights from anyone? Could it be a
I think
baseline of disease?
I mean we I mean the series does talk about anywhere between 6% to 20% patients ending up getting radiation pneumonitis. But in those cases, I think lung shunt function is still okay. But I'm still not getting the thing which is difficult to get our heads around is that the Y90 post treatment scan itself is showing that the lung radiation to the lung is is less than 10 degrees. So
Yeah,
then it becomes a little bit
yeah,
difficult in the sense to characterize it as a radiation induced lung injury.
yeah.
Is it possible that there is could be leaching of the Y90 particles after the scan because the half life of the Y90 is still closer to 3 days? But then I guess that's a bit like overthinking, I guess. And talking about the CT features, I think I reported the first CT scan that was done in January. That time, I think, if I'm not wrong, the patient was seen in a pre-anesthetic clinic and
Mm.
has a chest X-ray done because he was already planned for resection because the tumor was showing very good response and
Yes.
was planned for resection. And the pre-anesthetic chest X-ray showed there was some opacities. That time there was some equivocal history of infection, but and after talking to people Professor Kim in Korea, who published his longest series on radiation pneumonitis, his opinion is also that these CT findings are not very classical. There is a bit of overlap, especially in the. It could be a mix of both. Actually, there is some radiation-induced lung injury, but it's not entirely radiation-induced.
Mhm.
Yeah,
Your point about the decay, the half-life, what are the decay kinetics of Y90?
I think the half-life is 64.2 hours, right? Which is close
Yeah,
to like
2.5 days actually half-life of the year.
2.5.
2.5, around 2.69, there's 7, something like that, but around 2.5 days actually.
Yeah, so does that mean that the 9 grays is that's a snapshot only, right? Could he have cumulatively multiples of that 9 grays?
Until unless the additional Y90 migrated to the lung, and then we can see the accumulated radiation burden into the lung. But once the particle is stuck in the liver tumor area in the end arteriole, it is not migrating from there, it's stuck forever, especially glass sphere. So the size glass sphere is 20 to 30 micron actually.
Yeah.
And about the resin size is coming about 20 to 60 micron actually. So once it's stuck in the tumor vasculature is not dislodging and going to the lung area, but it may be, it could be possible reason to migrate, but I think I haven't seen this type of thing. Read any things. We started this Y90 treatment in 2020, 2002 actually, when Prof Ming was here from Australia. He started this one. I was here at that time. Last 23 years, this is the first case. Even I talked to the Dr. Loy. Have you seen any? He told me no, I didn't find anything radiation pneumonitis case in my calculation of the taking care of the patient, and is the same here too. So I haven't seen any case of radiation pneumonitis, and I was a little bit thinking why 6%, then there's no need to treat any patient, man. There's no need to treat actually. If you're giving 66% giving radiation pneumonitis, there's no need. How to explain to the patient? Should I go or should I not go? Because 6% is very minimal. It's very minimal. And nine gray is not damaging the lung parenchyma pneumocytes, not like a fibrosed or anything by with the 9 gray. So this is a question, is it still iffy? And of course, the radiology favoring radiation pneumonitis the only thing. And that's why I'm thinking how to, but I keep this record on this record, and most likely I will discuss with my senior in US, Sloan Kettering, about this one later on.
Yeah, because
October I'm going there actually, so I will discuss this case actually.
Nice. You say hi
And
to
Dr.
Joe.
Alvin, by any and definitely not for coroners or something, right? I mean, this
Well,
patient.
he wasn't sent, so we have no benefit of post-mortem.
Okay.
Yeah. But great, we're past 6:30, and well, precisely why we brought up this case to sell our minds and see if we get some answers down the road. I mean, whether cases were flagged or not before, we won't know, right? But that's our job to be on the lookout so that we learn. Great.
Thank you, Alvin. You did a good job to raise the red flag. We are hitting our head on the table. What happened to the patient? Is Y90 or something else? Or combined effect is a combined effect of the infection plus the Y90 is 6.1% lung something. Is a combined effect or single? I don't know about this one, but it's a good case actually. To
in the process, I learned how to treat a bit of HCC. I'll just send them to Glenn and Rahul. Okay, everyone. Don't forget the post event survey and everything else. Thanks a lot. Apologize for the technical issues. See you soon. Bye-bye.
All right. Thank you, everybody. Thank you.
Thanks.
Thank you, everyone. Justin. Yeah.
Thanks, everyone. Thank you.